Hello, everyone. My name is Laz Boros, and I'm the president of the Thyroid Foundation of Canada. I'd like to welcome you to our November Public Education webinar. Our guest speaker today is Dr. Anna Liu, who is speaking on Graves' disease. Dr. Liu is an endocrinology fellow at Western University in London, Ontario, with an interest in medical education. She completed her medical school training at the University of Ottawa and general internal medicine training at Western University. Once the presentation has been completed, Dr. Liu will answer general questions about Graves' disease from the audience. Catherine Keene, our administrator, will be acting as producer for this webinar. This means that she will be managing the technical aspects of Zoom. Some of our board directors will also be assisting. Kanista Primachandran will be looking after the Q&A section. Lori Martin will assist us in the chat room. This event will be recorded and made available on our website later this week. A little bit of housekeeping before we begin. Today we're using the webinar functionality of Zoom. This means that you can see and hear all the presenters, but your audio and camera are not active, and we're not using the raised hand feature. You're able to communicate with the other attendees using the chat feature at the bottom of the screen. So please feel free to join in. And you can use the Q&A to ask your questions after the presentation has finished. Please do not ask your questions on the chat. Use the Q&A feature to ask your questions. If you have any technical issues during the webinar, please reach out to Catherine via the chat feature. At this point, we're ready to begin with Dr. Liu's presentation.
All right, everyone can see my screen all right? Okay.
Yes.
Thank you so much, Laz, for that wonderful introduction. It's my pleasure to be here to give this talk on Graves' disease. Without further ado, let's get started. I want to emphasize that the purpose of this presentation is educational only. I do not have any commercial interests or relationships to disclose. So the outline of today's presentation is, first of all, to briefly review the thyroid gland and thyroid hormone physiology, define what Graves' disease is, how common it is, clinical features, diagnosis, as well as an overview of our treatment options, including antithyroid drugs, radioactive iodine ablation, and thyroid surgery. I'll briefly talk about symptomatic treatments as well. So the thyroid gland sits in the neck. It sits anterior or in front of the trachea, which is labeled here as windpipe. On the right is a picture of a woman with an enlarged thyroid gland, a goiter, and this is quite common in Graves' disease, as we'll talk about. To first understand what Graves' disease is, however, we have to review the normal thyroid hormone production pathway. It all starts in the brain, in the hypothalamus. The hypothalamus releases a hormone called thyrotropin releasing hormone, or TSH, or TRH, sorry. And TRH travels to the pituitary gland, which is also located in the brain, and tells the pituitary gland to release TSH, or thyroid stimulating hormone. The TSH then travels all the way to the thyroid gland located in the neck and tells the thyroid gland to produce thyroid hormone, which is T4 thyroxine and T3 triiodothyronine. T4 and T3 then travel throughout the bloodstream to the tissues, the cells, the organs to exert their effects. Now, it's important to note that this is a tightly regulated process, like a thermostat. So the body always wants to have the thyroid hormone in a specific normal range. And if it deviates out of that normal range, like the thyroid hormone is too low or too high, then there are mechanisms to get it back to the normal range. For example, if there is too much thyroid hormone, there's negative feedback to the brain. So if we follow this over here, there's negative feedback to the pituitary gland. The pituitary gland realizes there's too much thyroid hormone, decreases production of TSH. There's less TSH going to the thyroid gland, less thyroid hormones being released, and the thyroid hormone drops back down to a normal range. So then what happens in Graves' disease? There's a diagram here. You can see on the left is the normal thyroid function. The TSH is traveling from the pituitary gland to the TSH receptor, which is located on the thyroid cell. And through stimulation of the TSH receptor, thyroid hormone is released. Now, Graves is an autoimmune condition. Autoimmune condition meaning your body is creating antibodies, which are called TSH receptor antibodies. I'll most commonly be referred to these antibodies as TRAb, also known as thyroid stimulating immunoglobulins. And those antibodies actually attach onto the TSH receptor. You can see on the right here on the diagram, and tricks the thyroid into releasing too much thyroid hormone. And this is called thyrotoxicosis or hyperthyroidism. And so I want to emphasize the thyroid gland doesn't know any better. It's being tricked, and the issue is this antibody. Graves' disease is actually the most common cause of hyperthyroidism in North America. Tends to be more common in women, so 30.5 cases per 100,000 per year, versus in men about 8 cases per 100,000 per year. It seems to be linked to genetics, so family history, and smoking. Those both increase the risk of developing Graves' disease. And I want to emphasize that while Graves' disease is the most common cause of hyperthyroidism, it is certainly not the only cause of hyperthyroidism, but discussing those causes are outside of the scope of this presentation. So because the thyroid hormone can act in so many different parts of the body, there can be a number of symptoms that patients experience. And some patients may experience all of them, some only 1 or 2. One of the ones that we worry about is the cardiovascular effects. So fast and irregular heartbeat. Patients can very commonly have palpitations or sensation of racing heart, but sometimes it can cause an arrhythmia like atrial fibrillation. And atrial fibrillation increases the risk for stroke. And that's one of the reasons why we really emphasize going from a hyperthyroid to a euthyroid or normal thyroid state to reduce the risk of this happening. Patients can also get weight loss, diarrhea, tremor, goiter or enlarged thyroid, as we spoke about earlier, trouble sleeping, irritability, difficulty concentrating. They can also develop thyroid eye disease. There's a number of symptoms. One of them is proptosis or bulging of the eyes, redness of the eye, pain with eye movement. And we actually have a separate talk specifically on thyroid eye disease. It's available on YouTube, so you can check that out. Patients can also get a change in menstrual cycles. So the menstruation can become irregular or stop altogether, and that can be linked to infertility as well. They can have a reduced libido. They feel hot all the time, heat intolerance, muscle weakness as well. And it's not on this schematic or this diagram, but hyperthyroidism can contribute to thinning of the bones or osteoporosis. So how do we diagnose Graves' disease? First of all, the clinical features lead us to suspect that thyroid might be an issue. And remember, there's overproduction of the thyroid hormones, which we can certainly measure, so high free T4 and free T3. But the pituitary gland is still acting appropriately. It's decreasing that production of TSH to try to reduce the thyroid hormone production. So you get a low TSH, high free T4 and free T3, but you can also measure the antibodies. So that's what the issue is in Graves. You can measure TRAb. In some centers, this assay is not available, and so some patients can be sent for a radioactive iodine uptake scan, which will show diffuse increased uptake in the thyroid gland. However, this is not necessary to make the diagnosis. You can make the diagnosis on the biochemical or lab work alone. So I will be giving a brief overview of the several treatment options. Our main ones, as I mentioned earlier, is antithyroid drugs, methimazole, or propylthiouracil, PTU, I'll be referring to as, radioactive iodine ablation, and thyroid surgery. It's very important to note that this requires a discussion between patient and physician to arrive at the treatment option that is most suited to each patient's circumstances, their values, and their lifestyle. I've put symptomatic treatment here, but this doesn't actually decrease thyroid hormone levels. It just helps tone down things like palpitations, all the various symptoms we talked about. And typically we would use this while we wait for another treatment to kick in. And this consists of non-selective beta blockers, most commonly propranolol. So antithyroid drugs. These work by decreasing thyroid hormone synthesis. It's commonly the first treatment patients receive, so either as a bridge to another treatment or alone. And some patients can achieve remission of Graves' disease through antithyroid drugs alone. And how we define remission is normal thyroid tests for 1 year after stopping antithyroid drugs. This means that while you can be in remission for a number of years, the Graves' disease could come back and requires monitoring. And methimazole, I'll be putting this in my presentation as MMI, is generally preferred over PTU because there's less risk of adverse side effects, which we'll get into in the next slide. There are several exceptions. So PTU is used in a serious condition called thyroid storm. Patients are admitted to the hospital and very sick. And it is also used in the first trimester of pregnancy because there's the risk of fetal birth defects with methimazole. And this brings up an important point. If patients are planning pregnancy, it's very important to let their physician know as far as advance as possible so that treatment options around pregnancy can be discussed and the thyroid hormone levels are stabilized before starting a pregnancy. So this is just a little table about the adverse effects of antithyroid drugs. I listed prevalences when I could find studies on them, but keep in mind that the percentages will vary with each study. The most common adverse reaction is itchiness or minor rash, more common with methimazole, 6%, and less common with PTU, about 3%. This is typically managed with antihistamine therapy or over-the-counter medications without stopping the medication. And note that this reaction is generally more common with higher doses of the medication. Moving on to the more serious but rare adverse effect, one of them is agranulocytosis. This means a low white blood cell count. So white blood cells are important to fighting infections of the body. So patients who are on this medication and have an infection, but low white blood cell count, don't have that immune system available to fight the infection. So it's considered a very serious adverse effect. Any patient who develops a fever or sore throat on an antithyroid drug should let their physician know so that they can obtain a test of their white blood cell count. And it is definitely a reason to stop the medication. It's more common in PTU, so 0.3%, and methimazole is about 0.1%. Hepatotoxicity is another serious but rare adverse reaction. And what this means is liver injury. It can range from mild liver enzyme elevations to what we really worry about is liver failure. But this occurs more common in PTU, 0.048%, and methimazole's 0.026%. So it's definitely indication to stop the medication, and symptoms can include yellowed skin, abdominal pain, nausea, itchiness, light-colored stool, or dark urine. These patients definitely need to obtain tests of their liver function. And the prevalences here I want to emphasize are for liver failure specifically. So the three adverse effects that I've just discussed are most common in the first few months of initiating antithyroid drugs. Then they seem to not happen, but vasculitis is the exception. So the risk appears to increase with duration of therapy as opposed to the first three adverse effects. And what vasculitis is, it's another autoimmune condition. There are a number of symptoms. I've listed a few here, but it's certainly not comprehensive. Fever, joint pain, weight loss, muscle pain, rash, coughing of blood, inflammation of the eye. I was unable to find the prevalences in numbers, but it's quite rare and more common with PTU than methimazole. It is an indication to stop the medication, and the vasculitis tends to improve and get better altogether once the medication is stopped. So in terms of how long we treat patients for with antithyroid drugs, there is an algorithm developed by the American Thyroid Association 2016 guidelines, and this is also what we follow in Canada. In the diagram, I've put methimazole because that's our most common treatment option. The duration of therapy is typically 12 to 18 months, although some physicians will extend to 24 months. And keep in mind that because this is an autoimmune disease, and the issue is the antibodies levels can wax and wane. And the hope is that when you place patients on antithyroid drugs, the antibody levels will go down, and on discontinuation of the drug, the antibody levels will be at a normal level and the Graves disease won't flare up again. So what we do is we actually test the TRAb levels, the antibody levels, and the thyroid tests. And if all is normal, then we can try stopping the methimazole and monitor for relapse. The relapse rate is about 50% after 5 years. Patients will typically have regular thyroid test monitoring, and they should also watch out for symptoms of hyperthyroidism. So what happens if you relapse? Well, if you relapse, then there's a fork in the road here. Patients can decide to go for another 12 to 18 months of methimazole and then go through the cycle again, or they can decide to move on to more definitive treatment, is what we call it, radioactive iodine ablation or thyroid surgery. We'll talk about those in the subsequent slides, but essentially they get rid of the thyroid tissue, resulting in hypothyroidism. Now, if the patient already has an elevated TRAb level, then they are at the same fork in the road. So they can decide to continue methimazole or move on to the other two treatments. I want to acknowledge that the ATA guidelines state continued low-dose methimazole treatment may be considered in patients not in remission who prefer this approach as opposed to the other two therapies. There has been some evidence that prolonged low-dose therapy, is safe with low rates of adverse events. And as we remember, most of the adverse events tend to occur very early in treatment. And if a patient decides years later that they want to discontinue the methimazole, then that actually tends to lead to greater remission rates. There are several characteristics of patients that lead to or have been shown to have a worse chance of remission. So patients with a large goiter, a high titer of antibody, high degree of hormone elevation, prior relapses, severe eye disease, smoking, and who are underage. So this leads us to our next treatment option, which is radioactive iodine ablation. So first of all, what is this? It's radioactive iodine. It's typically administered as an outpatient. It is one dose of an oral medication. It's in a capsule or a liquid form. You swallow it, it localizes to and ablates the thyroid. So essentially, we're getting rid of the thyroid tissue to control the overproduction of thyroid hormone. There is a number of ways to calculate the dose, but one of the more common methods is to look at a thyroid uptake test and the thyroid size. It's typically a nuclear medicine physician who is arranging and administering this. Post-treatment, because this is a radioactive treatment, for a restricted period, patients need to avoid sharing cups, utensils, bed, sexual contact, and close contact with children and pregnant women to decrease the radiation exposure. And typically post-treatment, there's this normalization of thyroid function tests, then followed by hypothyroidism. This can take weeks, requiring levothyroxine or thyroid hormone replacement. Now, the thyroid hormone replacement requires monitoring as well as figuring out the dose that's right for the patient. But some patients prefer this approach because the thyroid hormone replacement does not have the rare but serious side effects of the antithyroid drugs. And so that can be attractive. And in addition, thyroid hormone replacement tends to be easier to manage in pregnancy. Whereas if you are on methimazole, you have to switch to PTU for the first trimester, and then potentially switch back to methimazole for the later duration of the pregnancy. Radioactive iodine is generally safe and well tolerated. Some patients can get a radiation thyroiditis with thyroid pain, but this is generally managed with over-the-counter pain medication and resolves after several weeks. There are some caveats, so we have to select the candidates for radioactive iodine ablation. Women who are pregnant or breastfeeding or actively trying to conceive, this is not recommended. In fact, we typically recommend that pregnancy be delayed for 6 months after radioactive iodine to establish euthyroidism or stable thyroid level going into pregnancy. If there's coexisting thyroid cancer or suspicion for thyroid cancer, this needs its own specific workup, and the therapy involves surgery, so taking the thyroid out. Individuals who are unable to comply with radiation safety guidelines aren't good candidates as well. And very importantly, if patients have active and moderate to severe or sight-threatening Graves' eye disease, we know that radioactive iodine ablation can make the eye disease worse. Other risk factors for Graves' eye disease include smoking as well. So we always encourage patients to quit smoking or limit their exposure to secondhand smoke. Approximately 10% fail the first radioactive iodine ablation. And as per the ATA 2016 guidelines, when hyperthyroidism persists after 6 months, retreatment with radioactive iodine is suggested. So this leads us to our last treatment option, which is thyroid surgery, otherwise known as thyroidectomy. Of course, it's removal of the thyroid, and it's a form of definitive therapy. And you ultimately end up with lifelong levothyroxine or thyroid hormone replacement because there's no thyroid to create thyroid hormone. And just like radioactive iodine ablation, this requires its own monitoring. This may be preferable for large goiters, especially those causing compressive symptoms. So a pressure-like sensation in the neck, difficulty breathing, difficulty swallowing. If patients have moderate to severe Graves' eye disease, this may be preferable because they're already not candidates for radioactive iodine ablation. Some may not want to stay on antithyroid drugs or have had an adverse reaction to an antithyroid drug. If there's a concurrent thyroid malignancy, we've already spoken about that the treatment would typically involve surgery. If there is a condition, a concurrent condition called hyperparathyroidism requiring surgery, then thyroidectomy might be a good option. Hyperparathyroidism is essentially a disorder that causes high calcium levels, and the cause is typically due to an enlargement in one or two glands called the parathyroid glands. And the parathyroid glands sit right by the thyroid. There are certain indications to take out the parathyroid glands. And if a patient meets that and also has Graves, typically surgeons would want to minimize the amounts of time they would perform surgery on the neck. So it might be a good idea just to take everything out all at once. The important thing to note is that it is recommended to have a referral to a high volume thyroid surgeon to minimize the risk of complications. So this can be a barrier because some people live in areas without an access to a surgeon such as this. Thyroidectomy is a surgery, so it's not recommended in patients who have substantial comorbid medical conditions that put them at high risk for complications. So think about heart, lung, kidney disease, or if there's a short life expectancy, for example, end-stage cancer. And it is not recommended in pregnancy because it increases the surgical risk. But if absolutely required, then thyroidectomy is preferred in the second trimester. First trimester, there's a risk of teratogenic or fetal birth defects associated with the anesthetic agent. There's also increased risk of fetal loss in the first trimester. And in the third trimester, there's an increased risk of preterm birth. Postoperative complications include those involved with any surgery like bleeding or risk of infection, but there are a couple that are specific to thyroid surgery. One of them being low calcium levels, which can be transient or permanent. And this is because, as I mentioned, there are the parathyroid glands that are right by the thyroid gland that can be affected. And you can see that here in this picture. So these 4 glands right here. There can also be injury to the laryngeal nerves, resulting in hoarse voice. And again, it can be transient or permanent. And that's again because of the proximity of these laryngeal nerves to the thyroid gland. But this is also why this is the main reason why we recommend referral to a high volume thyroid surgeon to minimize these risks of postoperative complications. So to wrap up the presentation, there's a few take-home messages. Graves' disease is the most common cause of hyperthyroidism in North America. It is an autoimmune condition caused by antibodies, TRAb, that attach to TSH receptors in the thyroid to cause overproduction of thyroid hormone. Symptoms range widely, but notable ones include thyroid goiter, thyroid eye disease, heart arrhythmias. Treatment options include antithyroid drugs, mainly methimazole, radioactive iodine ablation, and thyroid surgery. Antithyroid drugs have a 50% relapse at 5 years after discontinuation. Radioactive iodine ablation and thyroid surgery result in hypothyroidism requiring thyroid hormone replacement. But most importantly, what I want to emphasize is that each treatment option has its risks and benefits and should be individualized to each patient, what they're candidates for, their lifestyle, their values, and is a discussion between the patient and their physician. So thank you so much for your attention. I'd like to extend a thank you to the Thyroid Foundation of Canada, Laz, Catherine, and the team for inviting me for this talk. And so I think it's time for questions. Let me just stop my screen share.
Thank you very much, Dr. Liu, for a very interesting presentation. As you mentioned, at this point, we'll entertain some questions from attendees. Please put your questions in the Q&A section of Zoom. If you have put it through the chat, please redo it in the Q&A, because Q&A allows us to flag the ones that have already been answered. And so it's a lot better approach for us. So I'll hand it over to Hanista, who's going to be looking after a Q&A section.
Yes, so thank you, Dr. Liu, for that excellent presentation. We actually already have questions coming in, so we can start with the first one. So can Graves' disease be caused by stress? So we have an attendee who was diagnosed with Graves when she was going through a stressful time, but as soon as those stressors went away, her thyroid went back to normal. So I guess what's the association between stress and Graves?
So there are some studies that suggest that stress can actually be a trigger for Graves' disease. So essentially, it sounds like that attendee may have had a flare of the Graves' disease due to stress. And typically, these patients would be treated, again, go through the entire treatment process. It can be thought of as similar to a trigger being, smoking. There are a number of other triggers that have been studied in Graves' disease. It's difficult. It can be difficult to design a designed research study for stress, but it is one of the ones that is acknowledged to trigger Graves' disease.
Thank you. And our second question is, if someone with Graves has nodules on one side, does this raise the risk of thyroid cancer?
Not necessarily. I think if they have thyroid nodules, that typically has to go through its own workup. As I mentioned, there's many causes of hyperthyroidism. Graves is the autoimmune condition. Thyroid nodules themselves can also secrete thyroid hormone, and that can be delineated via a thyroid uptake scan. If the nodules are not secreting thyroid hormone, then they typically get ultrasounded, And there are characteristics on ultrasound that make the nodules more suspicious for thyroid cancer, and they would then undergo that specific diagnostic modality to figure out whether it's cancerous or not. So typically it would get sampled and the pathology would be looked at. But I don't believe that Graves' disease itself increases the risk for thyroid cancer.
Great, thank you. The next question is Graves the opposite of Hashimoto's, and are Hurdle cells involved?
That's a good question. So Hashimoto's is the most common cause of hypothyroidism, or low thyroid hormone level. And there's actually a separate talk that is also available on YouTube to be viewed. And it is an autoimmune condition. So it involves different antibodies. So you can, in a way, think about Graves as the opposite of hypothyroidism, but it is a different disease process in terms of the different antibodies involved. However, they're both autoimmune conditions. I'm not sure about the second part to the question about the Hurdle cells.
Okay, thank you. And can long-term heart issues result from Graves' disease? If so, what should we be highlighting to the cardiologist?
Right, certainly. So this is one of the most important things about hyperthyroidism in general, not just Graves' disease. Essentially, the concern is that if your thyroid hormone is elevated for a long period of time and is not controlled, it can lead to cardiovascular outcomes like increased risk for arrhythmia, atrial fibrillation. So atrial fibrillation can increase the risk of stroke. Typically, once the patient's thyroid hormone levels are brought back to a normal level, the atrial fibrillation is resolved. But certainly this needs to be shared with the cardiologist. Hyperthyroidism can increase the pumping action or stroke volume of the heart. And if a patient already has underlying cardiac disease and their heart doesn't work well, then that can adversely further exacerbate stress on the heart. So anytime anyone has a thyroid condition, hyperthyroidism, there needs to be close communication with the cardiologist for sure.
Right, thank you. Is there any association between COVID vaccination and the onset of Graves' disease?
Not that I know of.
Thank you. Let's see. If you have had thyroidectomy due to Graves, do you still have Graves' disease?
Oh, that's an excellent question. So thyroidectomy removes the thyroid gland to ultimately stop the thyroid from producing thyroid hormone, but it doesn't necessarily remove the antibodies, which I mentioned that's the issue with Graves' disease. Now, there have been studies that show after thyroidectomy, the antibody levels actually do tend to go down over time, but technically they could still be floating around. You could still have the antibodies, just no thyroid to produce the thyroid hormone.
I see. The next question is, can double vision due to Graves be permanent even after a complete thyroidectomy?
So what we're speaking about is thyroid eye disease due to Graves' disease. Now, thyroid eye disease is actually caused by the antibodies, okay? It can be exacerbated or worsened when there are high thyroid levels. So the thyroidectomy addresses the high thyroid levels. And over time, many of these patients have decrease in their antibody levels, which can improve the Graves' eye disease. But there could still be antibodies floating around and causing the thyroid eye disease. In terms of whether it be permanent, typically, I don't think it may not be permanent, but I'm not an ophthalmologist. So Graves' eye disease is typically treated by ophthalmology. There are treatment options that range from conservative to surgery and also depends on whether the thyroid eye disease is active versus inactive. So I think the best person to answer those types of questions would be an ophthalmologist. And also please check out our excellent seminar that was delivered by an ophthalmologist and available on YouTube specifically about thyroid eye disease.
That was a great plug-in. Thank you. So if someone has previously been diagnosed with Graves' disease, but have normal levels for 4 years, what are the chances of Graves' disease coming back?
Right, so the chances of Graves' disease coming back, or hyperthyroidism specifically, is about 50% over 5 years. I don't know if it's longer, like 10 years, 20 years. I don't have those specific numbers.
Thank you. It was mentioned that yellow skin is one of the adverse side effects of medication. How can you determine this in people with darker skin tones?
Right, so I think what I was referring to was the adverse of liver toxicity and liver failure. And the yellow skin is actually more a indication or symptom of liver failure. That gives us a clue that there might be something wrong with the liver. In darker skinned individuals, it's called jaundice. It actually is quite easy to tell. You can look at the eyes as well. The white part of the eyes actually become yellow, yellow as well. And actually, surprisingly, not as very difficult to tell even in in darker skinned individuals that they have yellow skin.
Thank you. So the next question is, does having Graves' disease count as an autoimmune disorder? So does this mean I'm less likely to be able to fight off other viruses?
It is a form of autoimmune, an autoimmune condition. It does not necessarily mean that you'd be less able to fight off other viruses. In autoimmune conditions, your body creates what are called specific antibodies or specific compounds or molecules that have very specific effects. And for Graves' disease, it just happens to affect the TSH receptor. Having an autoimmune condition does put you at greater risk of developing other autoimmune conditions, but there should be no effect on your ability to fight off viruses.
Great, thank you. The next question is, what are the risks or undesirable effects of radioactive iodine treatment other than thyroid hormone replacement for life?
Right, so the risks of, it's generally quite a safe therapy, provided that you're one of the candidates that should be offered radioactive iodine ablation. So we typically eliminate the population that it would not be safe in. So as I mentioned, pregnant, breastfeeding individuals, patients with severe Graves' eye disease. Typically, as I mentioned, the risk would be just a radiation thyroiditis afterwards, long-term levothyroxine therapy. It's quite a safe therapy.
Thank you. Are there any long-term health effects for resolved Graves' disease?
So long-term health effects for resolved Graves' disease. So either in remission or having had radioactive iodine ablation or thyroidectomy. Aside from, either requiring lifelong levothyroxine therapy and having the associated monitoring, and still having the risk of possibly developing thyroid eye disease, there are some studies that actually look at quality of life over the long term for patients with Graves' disease versus patients without Graves' disease. And it does show that the quality of life in general tends to be lower. But in terms of their health outcomes, I don't believe I know of any data that shows that there's anything else.
Great, thank you. Someone asked, are darkening of your nails considered a symptom of Graves' disease?
I don't believe that darkening of the nails is a symptom of Graves' disease. You can get onycholysis or raising of the nail in Graves' disease. You can also have darkening of the skin, typically on the legs. It's a rash associated with Graves' disease, but I don't think specifically of the nails that I know of.
Okay, thank you. Other than stress and smoking, are there any other known triggers for Graves' disease relapse?
I think those are the biggest ones. We've mentioned stress as well. Those two have the most evidence. Stress can also be a trigger, but it's very different. You know, we live in a stressful environment with work and things like this. It's hard to control that particular risk factor. There have been a number of things that have been tried to study over the years, like different medications that can contribute to Graves' disease. I would say that the ones with the best evidence are the genetics and smoking.
Okay, thank you. Another question is, why is natural desiccated thyroid not offered as a treatment after the thyroid is removed or ablated?
Okay, so this is a question now talking about hypothyroidism and the treatment of hypothyroidism after ablation. So I think the full answer is a little bit out of the scope of this presentation on Graves' disease. We have another talk that's available on YouTube that goes over the treatment of hypothyroidism and specifically addresses this question. But to summarize, the treatment of choice in guidelines is levothyroxine or T4. It has a long half-life. It tends to give very stable thyroid levels. But in some patients who still have symptoms of low thyroid, like they're still tired, they don't fatigued, they don't feel well, it can be considered to try combination therapy, sometimes desiccated thyroid hormone. However, this is a little bit of a gray area. And there are guidelines, European guidelines, but no specific North American guidelines on this.
Thank you. So someone asked, will a copy of this webinar be emailed to the participants? The video will be up on YouTube, so you can access it there. Let's see. Can you have Graves with normal eyesight?
Yes, very common. Most people don't develop Graves' eye disease, so that would be a subset of patients with Graves.
And this one asks, are there any specialists or organizations you know that the attendees can follow on Twitter or any social media that you're aware of?
Not that I'm aware of. You may actually be better poised to answer this question, Anista.
Specifically on Graves' disease, I don't know of any. There are a lot of thyroid organizations. Maybe Laz can better answer this.
Well, the American Thyroid Organization, not the ATA, but the other thyroid organization is called Graves and Thyroid Disease. So you can probably Google their name and you can get information from their site. So that's the American one. That's equivalent to what we do. ATA is more of a professional organization, the American Thyroid Association. And you'll find some good information too. There's a ton of information there, so you can look into that as well. And there's also the British Thyroid Foundation, and there's a couple of other thyroid foundations in Britain that you can check out as well.
Thank you, Laz. If you've been diagnosed with toxic multinodule goiter, do you have Graves' disease once your TSH, T4, and T3 levels are normal?
Right, so the toxic multinodular goiter may simply be due to essentially lots of different nodules that are individually secreting thyroid hormone. Graves' disease is an autoimmune condition. So as mentioned previously, the diagnostic criteria is really the characteristic lab findings, as well as there has to be the evidence of the antibody, if you're able to measure it, floating around and causing that issue. That may not be the case with toxic multinodular goiter. That's the best I can say for that question without knowing more detail.
Thank you. And in response to the previous question, Kim mentioned that there is a Graves support group on Facebook. So thank you, Kim. And I believe this is our last question. Does Graves' disease increase the risk of arthritis? And if so, how can you lessen the risk?
I don't know of any data that specifically links Graves' disease with arthritis. Although I will mention that if I'm speaking of osteoarthritis, Graves' disease is an autoimmune condition. So again, it increases the risk of other autoimmune conditions. So it can increase the risk of something called rheumatoid arthritis, which is an autoimmune condition.
Great, thank you. So thank you for taking your time and answering all our questions. I feel like we've asked a lot.
Thank you very much, Anista. That was great.
No problem.
I'd like to thank Dr. Hannah Liu for giving us a presentation on Graves' disease. We would like to show our appreciation by awarding Dr. Liu with a 2-year membership to the Thyroid Foundation. We would also like to thank our webinar team for making this educational event a success. I'd like to mention that if you have some spare time and would like to volunteer to help others with thyroid disease virtually from home, please call us on our helpline at 1-800-267-8822 or email us at info@thyroid.ca. You can also assist us by becoming a member or making a donation by visiting our website at thyroid.ca. As you exit the session, please take a moment to complete our short survey. You also have the opportunity to enter your comments here. This will help us improve future webinars. Our next webinar will be on February the 19th with Dr. Jesse Pasternak, who will speak on ultrasound-guided thermal ablation of thyroid nodules. All of us at the Thyroid Foundation of Canada hope to see you again soon. We hope you and your families are well and keeping safe. Thank you. Goodbye, everyone. Please fill out the survey at the end. Don't forget.